I want to thank everybody for joining us. Today we have a special Q&A session with Dr. Amesh Adalja. Dr. Adalja is a senior scholar at Johns Hopkins University Center for Health Security, and he has done a lot of work on emerging infectious disease and pandemic, and so we're very happy to have him here today. And chairing this Q&A session will be Ayn Rand Center UK Academic Advisor, Dr. Nikos Sotirakopoulos. Nikos.
Right. Thank you very much, Razi. So we're going to start immediately with the first question. And the first question, as it was submitted by us, comes from Karen.
Right. So first of all, thanks, Dr. Adalja. So my point is, I came across this point here when I heard Alex Epstein podcast, The Power Hour. So I'd like to know what you think about the point that being indoors increases our risk of a dangerous infection from COVID by A, exposing millions to higher doses of the virus, and B, decreasing immunity.
Sure. So we do know that transmission is much more unlikely to happen outdoors versus indoors. And that's because there's so many surfaces that people touch within a dwelling. They have much more contact with people within a dwelling than they do outdoors. That doesn't mean if you're by yourself at home that you're not safe. Obviously, you need another person to infect you. So where this point is coming from is the fact that in New York, after all they've done, they're still getting people infected. And the majority of those people who are infected are people who stayed home, but they're likely having visitors in their house that are spreading it. I don't believe there's any evidence, though, that being indoors has anything to do with your immune system. This really has to do with the fact that it's easier for the virus if there are two people that are indoors versus outdoors to transmit it between themselves.
Thank you. And can I ask a follow-up on this question as it was submitted? Would it be correct to think that the low-risk group would increase their immunity by going outside because it is a well-ventilated space and the exposure to the virus is possible but minimal? So this is basically a question on the virus load, and if we get a bit of it, let's say in the supermarket or somewhere outside, it would be a good thing.
I don't think it would be a good thing for anybody to get it. The load that's needed it's not going to be different on your immunity. Obviously, people that are at low risk are going to have that they're not going to have a very severe course of this illness, but you still don't want to be infected intentionally like that by going outdoors. It doesn't change your immunity. Obviously, if you can choose the way that you're infected, and being infected with the lower doses is better than being infected with a higher dose. Like, for example, a doctor might get a higher dose, but there's no way to really translate that into everyday life.
Right. Thank you, Amy. So the second question will come by Amy.
So there's so many questions I want to ask. I'll go with this one. So Sweden has a controversial strategy that is that one of their advisors, Johan Giesecke, described as their aim is not to stop the spread, which he thinks is futile, but to concentrate on giving unfortunate victims optimal care. So what do you think of his assertion that countries that have successfully suppressed this virus will actually suffer worse second waves if whether they're going to open up afterwards?
I think Sweden is a complicated case, and trying to understand what their strategy is a little bit complicated as well, because it's not as, the way it's been presented in the press isn't quite accurate. But what I would say is that the reason that we do social distancing is not to blunt any second wave or to worry about the second wave. It's to keep the cases from occurring at a level that overwhelms hospital capacity. And there are ways to go about that. And you're in a very different position if you have a lot of hospital capacity to begin with, and if you can get people to protect the ones most likely to be hospitalized. But I do think that this virus is endemic in the human population. It's not going to go anywhere, irrespective of what you do. The waves are going to come because until we reach herd immunity or we have a vaccine, because the virus spreads efficiently from human to human. So anytime you do a shutdown or a lockdown and you start to lift it, you're going to get more cases. What Sweden has done is not necessarily a lockdown. They've recommended people to do social distancing, and people do a lot of social distancing in Sweden anyway. They have very high rates of telecommuting. They have a lot of social distancing. It's built into their daily life. And some of the things are not happening. They're not having big concerts or sports events or anything like that, any big mass gatherings right now. So it's not the question that they just let this virus go. But even doing so, they've had a higher rate of they've had higher number of deaths. And I think that's going to go with it, go with that kind of a strategy. But the question is, do they have the hospital capacity to deal with it? And we're hearing a little bit about their hospitals being stressed. But certainly in a place like New York, if they wouldn't have done something, those hospitals would have collapsed. So I think you have to really look at hospital capacity when you look at these strategies. And I wouldn't say that Sweden's strategy, that these strategies are obviously right or obviously wrong. It really has to look, really have to look at the local demographics there and the local dynamics of spread as well as hospital capacity when you figure out what the best decision is for your area. And obviously there's other caveats into it, how long you're going to do it, what are you doing to try and alleviate the hospital capacity problem. All of that has to come into play. But it is, I think everybody is going to get second waves. This isn't going to go away. Some people may not have demarcated waves, but they're going to have a level of infection that continues on because it is a virus that spreads efficiently in humans.
Thank you. So, Josh, you have asked like 9 questions. Pick your best one. And if we have time, I'll ask one of the other questions at the end.
Okay, so yeah, I think the question that I'm most curious about of the lot is if we're lucky, and let's say we get a vaccine that's looking good, say like the Oxford one, and they say it's looking good for September. How long would it take to get enough production ramped up to say service the demand that's going to be needed for that? I've no idea about how long it takes vaccines to go from, hey, we're ready to go, to then produce 7 billion of them.
Yeah, so that's going to be the major challenge, making a vaccine on an industrial scale. And you have to think, even when you look at these optimistic projections of September, or even the 12 to 18 months that you hear a lot, those are very optimistic because vaccine development is something that's often measured in years, not in months. And you have to think about all of the problems that could happen during scale up and manufacturing, because these are all novel technologies. Even the Oxford vaccine being manufactured in England and being developed in England is using a novel vaccine platform that hasn't been used in an approved vaccine yet. So there's a lot of issues with what will come up during the clinical trials. How do you study enough people to be able to be sure that A, that it works, and B, that you know what the side effect profile is in individuals. So that's going to take some time to do, although they're moving at rapid speed right now, faster than we've ever moved with the vaccine. When I think the vaccine is available, suppose it does get available in September, at that point, it's likely to only be offered to healthcare workers and high-risk individuals. It's going to come out in tiers, similar to what happened during H1N1 in 2009. I think you're talking about a years-long process to be able to vaccinate the entire world with this. So we will be battling this without a vaccine for some time.
So every now and then, I'm going to read some of the questions that were via the internet. So someone says, I'm taking 2 flights next week with a long transit in an airport. Should I worry? And how can I protect myself? Parentheses, masks, move around versus staying in the same place, etc. So what about flights?
So it all depends upon your risk. No activity in the midst of this virus, no activity is going to be risk-free. You have to start thinking about your own life, how vulnerable you are to having a severe complication. Do you take care of your grandmother or something like that? You have to think about these things in your own life and then kind of go forward. What you can do in an airport situation is try to social distance the best you can. Wash your hands a lot, refrain from touching your face. Many of those places are going to require you to wear a mask. There's some debate over the mask data. So if you have to wear one, wear one. If you don't have to. But most places are making you wear a mask. I think that you want to try and stay away from people that look like they're coughing or sneezing, but it's very hard to do that. So the best thing you can really do is just the simple stuff of washing your hands a lot and not touching your face, and trying to minimize the areas that you're in that have a large crowd. So if there's a line at McDonald's, but there's no line at another restaurant, go to the other restaurant. I'll try to sit on a plane with the middle seat open if you can. Just a lot of common sense, but it's no activity is going to be risk-free. And you really have to decide for yourself now how you want to approach that risk.
Thank you. So the next question will be a live question. So let's go to Alejandro, who has also asked more than 1 question. So Alejandro, I'm going to ask you to pick your best one.
Yes. My question is, how should one interpret the studies that try to estimate the real death rate of COVID-19? How much can we extrapolate to the world on the findings of, say, California or other places in which they have tested?
So this has been one of the major difficulties, is understanding what the true case fatality ratio or the infection fatality ratio is. And that's because all of the data has what's called a severity bias in it, because people that are getting tested are coming to the hospital, for example, or going to their doctor's offices. So we have had a hard time figuring this out. And we may not know for some time until we do widespread antibody testing to understand what the case fatality ratio is. The best thing that I can tell you is that it is below 1%. likely probably around 0.5%, but we still need to get more data to exactly know what that is. And remember, that's an average fatality ratio. It's not everybody. So there are people in a group of above age 70 where the case fatality ratio may be 15 to 20%, especially in those who are hospitalized, versus someone who is 18 with no health problems where the case fatality ratio may be much lower than 0.5%. And this is something that happens during an outbreak. You just don't have that data until after the fact. What the real number I think is important to look at, though, is the hospitalization rate. What percentage of those infected require hospitalization? Because that's what's driving hospital planning and hospital capacity concerns. And I think the initial models had that around 20%, and it seems to be much lower, maybe closer to 5% is the real hospitalization rate, which is why all of those models and those projections were off, and why the need for ventilators wasn't as much as we thought, because the hospitalization rate was off.
Thank you. So now I'll move to more questions from the internet. Do you think that reports about French and Spanish athletes getting ill after the military games in Wuhan last October 2019, have any credence?
There's lots of stories about these types of things. What I can say is that they're definitely, I don't think that this virus came from anywhere other than China. I think coronaviruses live naturally in bats. It probably spilled from bats into another animal and then into humans. We may never find patient zero. We know that this was spreading in Wuhan at least mid-November, most likely before that time, but we don't know exactly when it started. I don't think that this came from anything other than I think that there's all these theories about, did it come from a lab, did it do this, did it do that? Most of the evidence points to this being a natural event. This is what coronaviruses do. And I think it's become less important now, other than trying to find out which animal was the middle ground, because we don't think it came from bats directly to humans, so that we can understand what that animal is and how to handle that animal better in the future if it came from a market or from something like that. But I don't think that any games caused it. But I wouldn't be surprised if you look back. So maybe you look in October, you're going to find cases there, and there are people. I think you might find people that were sick, and it was just such a low level that they were unnoticed. And plus, we're not very good at diagnosing many syndromes. But I don't think that, I don't know the specifics of of what they're talking about with the Spanish games there. But
right. Talking about things that we know more than we did. How about the issue of immunity? So another question says, Professor Ferguson's defense was that he now has immunity. Do you think he knows more than they are do you think they know more than they are letting on regarding immunity? So basically, are we in a better position to say that if you've had it, you have some immunity for some time?
Yeah, so I do believe that. And I don't think that Dr. Ferguson knows more than he's letting on. I think this is not some kind of secret or conspiracy. We believe that if you are infected with this virus, you're likely unable to be infected with it for a period of time. We don't know how long that period of time is. Maybe it's several months to a year. With other coronaviruses, we know that people can be reinfected maybe a year later in a lab setting, and those infections are clinically silent, meaning they have no symptoms. We don't know if those people are contagious or not. But from people who get this virus and recover, there is a period of time where they are not able to contract the virus. But none of that has been validated or studied. But that's what we can actually know based on other infectious diseases and what we've seen epidemiologically. But the studies need to be done to prove it definitively.
Right. And in the same category of questions, are the antibody tests good enough yet?
The antibody tests have varying degrees of sensitivity and specificity. What we're worried about is many tests give you false positive results. And that's because remember, this is the 7th human coronavirus that's been discovered. And 4 of those coronaviruses we deal with every year, causing about 25% of our common cold. So many people have antibodies to those other coronaviruses. However, there are now probably about a dozen of the tests that are available, at least in the United States, that do have high levels of specificity that are reliable. I don't know which ones are available in the United Kingdom, but for example, the one made by Roche has very high specificity. And then the other ones, there are other ones as well that you have to consult the local stuff there in England for me to tell you which ones are available there.
Yeah, unfortunately, it's not that we have the option to go and buy them, so it doesn't matter yet. But yeah, England is behind that. So a question in the chat. How come there are no cases in China? I assume it means how much there are no many new cases in China.
Yeah, so China still is a mystery, and it's unclear how much of that information is completely complete and how transparent they're being. We do know that they're reporting very few new cases now, and the cases that they are reporting are often importations from other countries. which I think serves their purpose well to say that this is an American here that gave it. And that's actually been the case. The New York Times has done some stories on the stigmatization of Americans that's going on now in China. But I don't know. It doesn't make sense to me that they could have 0 cases because the virus didn't go anywhere. The virus is something that's established itself in human populations, and they could not have captured all chains of transmission at that time. So I suspect that there are cases there that are maybe very mild or not coming to light, but many of us don't quite completely take all of the data coming out of China at face value any longer.
Right. Another question, how many excess deaths are you predicting from the lockdown, as for example, parentheses, cancer, etc.? And do you predict that there would be more deaths from the lockdown rather than from COVID-19 itself?
So I can't put a specific number on that. We do know that it's going to be measurable over time, and we may not see many of the things that would be exacerbated during a lockdown are going to you're only going to see that later. So for example, if someone doesn't get a colonoscopy and their colon cancer gets diagnosed later, or they don't have a cervical cancer screening, or they don't get a mammogram, or their surgery got put off, that you're not going to see for probably some time. And I would say it's going to vary depending on the geographic area. So in a place like New York City, where this has basically become the leading cause of death, I don't think you're going to be able to discern any kind of difference there, because it's going to really matter, and it's going to get different depending upon how long the lockdowns were. And already in New York City, for example, in most of the United States, hospitals are now have already started to resume their normal operations, meaning they're doing all of that. So it may be that we averted the worst of it, but this is definitely a cost that wasn't considered very much, and it's something that we need to measure in the future, because we know it's also the deaths from psychiatric illness, from substance abuse, domestic violence, all of those things go up during a lockdown. And I think there's more recognition of that now, but I don't know that we'll be able to see this measurable. And then there's also going to be decreases. For example, trauma deaths have gone down significantly from car accidents and shootings. So it's going to be hard to parse out that data, but it will take a while. And the other point is the longer the lockdown occurs and the more strict it is, the more likely you are to see those deaths. If you have a loose lockdown, and most of the US lockdowns we're pretty loose compared to what we saw in China and even some of the European countries. So we may not completely get it, but it is a cost that you have to bring up and talk about.
Right. Now, there are some questions in the chat and from the internet regarding herd immunity. So to put them all together, where would you put the threshold for a country reaching herd immunity? And also, does it matter whether this part of the population is not so vulnerable people compared to everyone reaching a specific percentage?
Well, so for this virus, we need to get the herd immunity threshold is probably around 60% or higher based on its contagiousness. So we're not near there in most countries. And that herd immunity is an immunity level that you want to see in the entire population to give the virus. So whatever person when the virus encounters persons, it finds so many immune people that it actually cannot transmit very efficiently. So we want that to be basically a homogeneous level that's in every population you look at. It has that kind of 60% level with no pockets where it can spread.
Right. So another question from the internet. So if most people are locked down, how do we still have new cases? Can I get COVID from the supermarket?
So it's important to remember that these economic shutdowns were not complete. People were still, there's all these essential workers, people going out, working in hospitals, working in grocery stores, in restaurants, for takeout, drivers, people working at electrical power plants. This virus remember, there's no population immunity to this virus, meaning nobody has seen it before. So if the virus finds people, it's going to infect them. So even as tight as some of the shutdowns and lockdowns were, there are still people out there doing things, and that's going to give the virus an opportunity to spread. So I don't think that you shouldn't have a notion that we can get this down to zero. Even the tightest shutdowns, people still need to breathe, and people recognize that there's certain industries that are permitted to work, and that's going to give the virus opportunity. And you technically can get it from the supermarket. Your people are going to the grocery store, and their people are touching things, and people may or may not be sick when they're there. So there are opportunities that even in a shutdown, that this virus will find.
Right. So what do you say to those who said that the Hong Kong flu, given the population number at the time, the less obesity, I assume it means the lower levels of obesity and lower average life expectancy was worse than COVID, and that there was no need for shutdown then? And this is also related to this article that became viral about Woodstock, the music festival happening in the midst of a global pandemic?
Okay, so in 1960, so I can talk about the U.S. number. So if you look at 1968, 100,000 Americans died from the Hong Kong flu. It's going to be more than 100,000 for this, just off of the face of it. So in that sense, it is going to exact a bigger death toll. And it may be that we have more vulnerable populations now in 2020 than we did in 1968, meaning there's more older people, there are more people that are living with all kinds of comorbidities. So in that sense, yes, we're at a more, where some of the deaths that we're going to see from this are a result of the fact that we have the luxury of living longer, and that there are more people that are in their 7th and 8th decades of life now than there were in 1968. But I do think that if they would have done lockdowns and shutdowns in 1968, they might have gotten some benefit from it. It probably wasn't thought to be worth it because of the fact that this was a flu, even though the population immunity was low because it was a novel flu virus that emerged. I think that people have a way of discounting flu and don't actually give it the respect that it does. And the 1968 outbreak was disruptive. And I'm sure that mass gathering events like Woodstock did play a role in how it spread around. And so I think that it's sometimes unfair to compare these things to something that happened in the past. And they probably could have done a lot better with that. And I don't necessarily advocate lockdowns or shutdowns, but I think the way that when people bring this up, it's kind of in a disingenuous manner. Because so if you look at a normal flu season, maybe 50,000 Americans will die in a normal flu season. So 100,000 died, so it was double. But but this is additive. So we had a flu season here that maybe 40,000 people died from influenza in the United States in this season. And now we're going to add probably 150,000, 200,000 on top of that. So it's important to not try and replace the two from them. And I think that's sometimes what's happening is people aren't realizing this isn't in place of flu. This is in addition to flu. And we don't want another flu. We don't want this thing to keep coming around every season and killing tens of thousands of Americans every year, or however, and millions or hundreds of thousands in the world every year. We don't want this to establish itself and become like flu. We want to take the risk away.
Right. So I will add now my own question, which is we read articles by people who are scientists that say that what plays also a role is how long you are exposed to the virus. So for example, they give some models that if you spend, let's say, 50 minutes in the supermarket, or if you spend 20 minutes with someone close to close. Would you give us your view on these? So is it safer to just have shorter interactions, or if we go somewhere in a closed building, for example, the grocery store, that we make it as quick as possible?
So I do think that the time you're exposed does play a role, but that's more for an individual. So if you're exposed, if someone has coronavirus and you're around them, the longer you're around them, the more likely you are to get the virus. Something that if you're around them if you walk by them on the street, or if you just see them and you walk by, you're unlikely to get it. But if you spend 10 minutes, 20 minutes, you're more likely to get it. But you also have to remember that it's also the number of contacts you have. So it's a function of your duration of exposure and how many people that you are exposed to. So suppose you went to a rock concert and there was lots of people there with coronavirus, you'd probably still get it, even though you never spent much time with any of those individuals. It was just a number of people that you were, in fact, giving the virus more and more chances. So this is much more interesting this is much more important when you're looking at a contact, when you're investigating a case, saying, okay, who were you exposed to? And you say, oh, this guy, I opened the door for him. You probably didn't give it to them, but this person I sat down and had lunch with. That's enough of an exposure to say that person has been significantly exposed and needs to be watched, not the person that you opened a door and just walked by you. That's where that comes from.
So just for the layman, and I mean myself, because I don't get one thing, does this have to do with whether you get a load or with the magnitude of load?
Both.
Both.
So you could be around somebody for 10 seconds and they sneeze in your face and you've gotten it, even if you were. So it has to do with both of that. It's just in general, transmission events tend to occur. They're more likely to occur the longer you spend time with the person. That doesn't mean that you can't get one from just a fleeting contact. It's just that it's unlikely to be the case unless there was some kind of way that you were exposed to their respiratory secretion.
Right. And one of the last questions, do you expect that life expectancy can be influenced by that? Because someone says this might have long-term effects that will last for decades, and life expectancy will go down, he predicts. Do you think this is credible?
I don't think so. when you look at 1918 was the only pandemic that took down the life expectancy, and the average age of death is just a quiz question. Nikos, how old was it? You know, the average was 27.
27.
So the average age of death here is probably in the 70s. So it's unlikely to make a dent in the health in the lifespan.
Okay, one last question. When do you think schools and colleges will open in the United States? And let me add, would you make a distinction between schools and colleges?
Okay, good. Okay, a couple things. So schools and school closures for elementary schools, that was very controversial in my field. That many of us, including myself, did not think it was justified because most of the data that comes for school closures comes from influenza, and it's not very good, even from influenza, that it's very beneficial. And this is a totally different type of virus. We know that children can get infected with coronavirus. We know that they have viral loads in their nose. We know they have lots of contacts, but we haven't seen much evidence of them actually driving cases or causing transmission events. So this was something we didn't want to do because of the lack of evidence and the fact that we know that some children rely on the school to eat. That's where they get their meals. Some people, children need to be taken care of. Now parents can't work because they have to take care of their children. And we know that there are long-time psychosocial benefits. I mean, that are psychosocial problems if you're not educated, if people are not getting an education. So there was a lot of negative to this, and it's happened, and it happened. What's happening now in the United States is there are already schools open in 2 states, in Montana and Idaho, which are very small rural states, do have some schools open. Many other places have closed for the rest of the year. I do suspect we will probably open in the fall. It will be modified with more social distancing. There is probably a little bit more of a concern with universities because people come from all over the country to them, but many universities are likely to open. And I think what's going to happen over time is there's going to be, you know, a risk perception change, and people are going to start to be able to live with this virus. Obviously, if you're an elderly professor that's 80 years old, you have to be careful about who you're teaching. Or if you're a school teacher that's old, those people are still going to need to think about their risk and what risks they want to take. But I do think that you're going to see schools and universities open in the United States.
Right. Thank you so much, Amy. So, Razi.
Yeah, thanks, Nikos. And a massive thank you to Dr. Adalja. I know you're incredibly busy at this time, so I know we all appreciate you taking the time to talk to us here. And thanks, Nikos, as well, for going through the questions at rapid speed so we could get as many of them in as possible. This event and all our events go on our YouTube channel, so their link is in the chat right now. You should subscribe to that. And the next event that we'll be back here for is in 2 days, What's Next for Feminists, where we'll be discussing, how the feminist movement will post in a post-COVID world. Nikos will be speaking there, as will Zoe Strimple from The Telegraph. So I hope you join us for that. And of course, on Saturday, we'll be back with Josh for another event on psychology. So thanks, everyone. See you Wednesday.